going to go ahead and get started. If you don't have a spot, there are spots. I see a few aisle seats even. So good afternoon and welcome to our event today. My name is Laura Bowman and I'm the Community Relations Director for Mayo Clinic here in our community and in Southwest Minnesota. It's really great to see a full room for our event today. We want to welcome all of you, our community members, and I know we have many elected officials here, so thank you for taking time of your day to come. Our Minnesota State University Mankato students and faculty, wow, there's so much energy. I work in healthcare, we're a pretty serious business. You should expect that when you come for your healthcare, but I love the energy and enthusiasm on campus. It's really great. And also we have a lot of our Mayo Clinic Health System employees here today as well. So thank you everyone for taking time of your day. So while the topic we're going to talk about today is very real, it's a very serious topic, obviously. We at Mayo Clinic are very committed to this event and to doing our part, one piece of the puzzle, and helping to provide this education here at the event today and really raise the awareness and continue the awareness that's already been raised in our community. One of the reasons this event is such a success is because it's a partnership, and we're incredibly thankful for our partnerships with our colleagues here at Minnesota State University Mankato, and obviously with the documentary being produced, as well as our partners at TPT, Twin Cities PBS, who made this happen, who made the documentary happen. So thank you to our partners. And we're also really extremely blessed to have a panel who you do have information. They'll be introduced in a little bit here, but we have a local panel to really help us after the viewing to have a really great dynamic conversation as we're having our viewing today. So thank you to all of our local experts who have joined us today. So as I mentioned, the documentary, The Opioid Fix, is a documentary co-produced between Mayo Clinic and TPT Twin Cities PBS. So there are 3 episodes in this documentary, and so we will be showing the 3rd episode at today's event. And so without further ado, I'd like to introduce Steve Spencer, who is the senior producer at TPT Twin Cities, and he's going to really set the stage for the viewing today and bring some context around the opioid fix. So, Steve.
Just to reiterate, it is spectacular to see this crowd. I know some of you may have been required to be here, but we'll make it worth your while. So Twin Cities PBS has wanted to do something on opioids for quite a while now, and a couple years ago you may have seen Ken Burns did a history doc on Mayo Clinic. Of course, we had a big event for that, and our people were there, and Mayo's people were there, and they all crossed paths and said, well, we want to do something on opioids, and Mayo's we want to do something on opioids, so we created this partnership. We made 3 shows, and the guiding principles of this were education, prevention, and solutions. You know, this is not an investigative documentary series, it's not a gotcha situation, we're not putting anybody on trial. We are looking for a way forward. The first show is a lot of background and history about what are opioids? Why do we take opioids? When do we take them? How did we get into this situation? But it's also, a big part of it is also about racial disparities, because as you're probably aware, there's very dramatic disparities in the opioid crisis, in particular with the Native American community. We went out to White Earth Reservation and profiled a program that they have where they're working with young moms to get off opioids and heroin. And they're saving lives. The second show focused a lot on community, and in that regard we went to Little Falls, which is in central Minnesota. They had some very serious problems and still do, but their approach now is community-based, and we are talking about the entire community. Law enforcement, healthcare, pharmaceuticals, corrections, public health, the schools, theater kids in the schools, putting on improv acts for their classmates. And in that way, they are taking a very holistic approach. But we do look at a lot on the role of law enforcement, because it plays a huge role in this and how they're changing some of their attitudes about it. We're not going to arrest our way out of this problem. In the second show, we also start looking at non-pharmaceutical treatments for chronic pain, and I'm sure our panelists will have a lot more to say about that. The third show you're about to see, so if I have to explain it to you, then I have failed. But just a couple more things. When we started this at the very beginning in doing the research, I was struck about something that I read. You know, America has 5% of the world's population and 85% of its opioid addiction and dependency. Why is the wealthiest, most powerful country in the world in so much pain? The other thing was we were very deliberate about not stigmatizing people who are struggling. That's not going to help anybody, and we want to find ways forward for everybody. So demonizing those people was something that we definitely didn't want to do. So with that, I'll turn it over to Chris.
Uh-oh. Trying to turn this off because there we go, because I have my lavalier on as well. I'm here, I'm Chris Rutherford. I'm the Dean of the College of Allied Health and Nursing, and I'm here to provide the university welcome to you, and I will be the moderator of our panel discussion this afternoon. I'm so proud of the partnership that we have with Mayo Clinic Health System, but I'm just thinking about my videotape. I think I've got a microphone in my face. There we go. Is that better, Robert? Got it. All right. The relationship that we have built over the years with Mayo Clinic Health Systems is one that I'm really proud of. We share a lot of things in common and have been able to partner to accomplish a number of things that our students have benefited from and that the community has benefited from. So I'm so proud of that relationship, and then to have this partnership with Twin Cities TPT to come and share the documentary with us, I'm really excited about. Let me just say a little bit about how this is going to roll, because there's going to be kind of a lot of movement. We've decided to break the documentary into 3 segments. I'm going to introduce our panel in just a minute, and we'll lay some groundwork, have some conversation, and then we'll get up and go to the wings, and then they'll run the first segment, which is about 10 minutes long. And then we'll come back out, and we'll do a few more questions, and then we'll leave again. And then we'll come back out for the third segment. And at the end, we'll also bring Steve back up, and we'll take question and answers from the group. So I'm excited about that. Before I bring our panel on board, I just want to introduce some dignitaries with the university that have chosen to join us today. I see 2 people back here. First, I want to introduce Interim Provost Matt Cecil. Thank you so much for joining us. Wave, clap. And Vice President Bobby Fleischman, who is Vice President of Strategic Partnerships. So they're here today. And I would say one of the main reasons they're here today, besides the important topic that is on our agenda, is to show how important we value our relationship with the community, with our students, with our Mayo partners, and to show that we really care. So with that, I'm going to ask our panel to come forward. I'm going to move over there, and I'll introduce them after they're all out. So, am I too loud? All right, good? Okay, so first I would like to introduce Dr. Jason Doffenbach, who is a physician in the Department of Pain Medicine at Mayo Clinic Health Systems here in Mankato. He focuses his clinical work on a full spectrum of pain medicine practice with special clinical emphasis on, here we go, interdisciplinary spine care and neuromodulation. I am the Dean of the College of Allied Health and Nursing, but I'm not a nurse. I'm a speech pathologist. Next, we have Dr. Matthew Schumann. Thank you. is a licensed clinical psychologist and works as a pain psychologist with Mayo Clinic Health System in Mankato. His primary clinical interests are delivering and providing education regarding evidence-based approaches for chronic pain management across the lifespan. Dr. Schumann has been active in facilitating the opioid education workshop at the Simulation Center at Mayo Clinic Rochester, and we will see you in the second segment of this third episode of the documentary. Next to him is Thad Schunkweiler, who is a licensed mental health professional and works as an assistant professor in the Department of Health Science here at Mankato State University and Minnesota State University, Mankato, and in the College of Allied Health and Nursing, so he's one of our own. Professor Schunkweiler's work has helped guide policy at both state and national levels, and in fact, I ran into him in the hall one day. He looked like he had the deer in the headlights look, and he had just gotten off the phone with the governor, asking him to, the previous governor, Governor Dayton, asking him to serve on a task force. We also have Jeff Wurzel, who is a lieutenant with the Blue Earth County Sheriff's Office and is currently assigned to the Minnesota River Valley Drug Task Force as the commander. Lieutenant Wurzel has been supervising the Drug Task Force since 2015 and has participated in hundreds of felony drug and weapons cases to include drug overdose deaths. So welcome, panel. You didn't even have to do a thing. You got an applause. All right. Before we watch the first segment, I want to go to our panelists and ask them to share a few thoughts. We've sort of scripted these based on expertise. So first, if Jason and Matthew, if you would be willing to share some perspectives on what are opioids and why do we use them? You can start. You've got the microphone.
I do. So, an opioid, which we're all familiar with, and you'll hear Dr. Gazelka, I think in our first segment, talk a little bit on this as well. But when we look at, from a pharmacologic perspective, what an opioid is, our bodies all have what's called an endogenous opioid system, meaning that we have receptors all throughout our body, central nervous system, it's stretching through a number of different systems, through the GI tract, through the endocrine system as well. And so we have receptors which are responsive to these chemicals, really. And so if we look at this really from a pharmacologic or a chemical perspective, an opioid is any compound or any chemical that attaches and binds to these receptors in our body. And if we look at that all the way from an illicit substance, heroin, or a variety of other substances, those are all things that attach to those. And then we have sort of a pharmacologic perspective, and where we synthesize these compounds in a lab, put them into a pill or a patch or a IV formulation, and then we can inject those or take those prescription medications, and that's also something we refer to more as an opiate. And that are everything from a natural kind of substance, like morphine, to a semi-synthetic product, which is something that's commonly seen as hydrocodone or oxycodone, or a fully synthetic product like methadone. And so these are a variety of chemicals that are given therapeutically, at least from my perspective, generally speaking, they're given therapeutically in an effort to treat patients with pain disorders. And we, classically, when you look in a textbook, it's a moderate to severe pain condition. Now, over the past probably 40 years, these have been utilized very commonly in an acute pain condition, so something like a fracture, a trauma, surgery, and we use these to modulate patients' pain. And as we'll discuss and get into, that has transitioned over the past 25, 30 years for patients with chronic pain disorders. And so the intent really is to treat patients therapeutically with a moderate to severe pain condition. That's what a textbook response would be. These are powerful chemicals, powerful things that act all throughout our body, and obviously we'll kind of delve into some more of that. But that's where, from a perspective of sort of a therapeutic intervention, that's why we use an opiate or an opioid medication.
Thank you.
And I might piggyback on what Dr. Doffenbach had said about why we use opioids is also complex. The purpose is to hope. The purpose and hope is to modulate pain. They're often the function starts to change or can change. So with regard to distress and with regard to emotional considerations, opioids are often used to help decrease distress, often used in circumstances of undiagnosed substance use disorder, and often particularly used with other comorbid mental health diagnoses on top of pain as well.
Okay, I'm going to turn to Thad and ask Thad if you could talk a little bit about what is the opioid epidemic and how did we get here?
So what is this epidemic? I have 2 minutes to teach something that takes me a whole semester here on campus. But let's first start with that word, epidemic. That's not a word that we throw around lightly in healthcare. That's not something that is typically used by the Centers for Disease Control, but that is the word we're using for this crisis as an epidemic. And to put it into kind of a quantitative perspective, roughly about 47,000 people died last year of an opioid overdose, or about 130 people a day. So it kind of gives you some perspective as to what that looks like. So it means that, you know, if today half this room would be gone from an opioid overdose. That's what's happening here in this country. To think about how we got here, it's pretty complex, but to give you the basics of it, we've been using opioids for a really long time. However, we've kind of reserved them in medicine for kind of very special circumstances because we always knew that there was this addiction potential, this dependence potential, and so medicine was very hesitant in using that. Well, that all changed in the late 1990s when the pharmaceutical companies kind of made these promises about certain opioids that said, look, we know they're addictive, but we made one that's maybe not quite so addictive, and really changed the landscape in prescribing habits and things that Steve does a great job in outlining in the first 2 episodes. Well, what happened was we saturated the communities. We flooded the markets with opioids. And after a few years, we recognized, shoot, we've made a big mistake, and we got to stop doing this. And for lots of people, it just meant the end of that treatment. But for a sad number of cases, those people became physically dependent on those opioids. And when they were unable to get them medicinally, they would turn to the streets. And what they found on the streets were drugs like heroin and other, cut drugs that really kind of accelerated the amount of people we were losing with this. I do think it's also important to note, and I'm really happy Steve touched on this, that there is a racial disparity in this epidemic. It doesn't impact people equally. And I'll bring it locally here to Minnesota. There was a Department of Health report about 18 months ago, 2 years ago, that came out that found that African Americans in Minnesota were 2 times more likely to die from an opioid overdose than whites. And when you then look at the Native American community, that number jumped up to 6 times more likely. So not only is there a healthcare issue, not only is there a public health issue, there's really a justice issue about what this is doing to our communities. So it's definitely more complex than that. If you want to know the whole story, take my class next semester, and we'll definitely get into that.
Great plug, great plug. And Jeff, if you would talk a little bit about what have been some of the local consequences of this epidemic.
So locally, we're actually pretty lucky here in southern Minnesota compared to northern Minnesota, Duluth, St. Louis County area, and the metro. As far as the opioid issue here, when I talk about opioids, mostly what I deal with is the illegal stuff like heroin, fentanyl, and stuff like that. I look back through 2018, 2019, we did 20 heroin investigations compared to over 100 meth investigations. So in comparison, the heroin issue in southern Minnesota is good. Not good. It's not as bad as it could be. I'm not complaining about it. We did in the last 2 years have 2 opioid overdose deaths. Both of them were women in their 30s. Both of them were found by their own children, and both of them were involved in fentanyl. Other than that, as far as non-fatal overdoses, 35 of them were reported to law enforcement between 2018 and 2019. I don't think that's even half of what actually occurred, because a lot of people are have their own naloxone or taking care of themselves, or they simply just call an ambulance and it doesn't get reported to us. It's a medical emergency, so we're really not privy to the information unless we're called to administer life-saving measures, which the law enforcement routinely does. As far as heroin seizures, I think over the last 2 years, 25, 30 grams of heroin is about all we've taken. Much more of the opioids we seize are fentanyl pills, which are oxycodone pills, hydrocodone pills, or they're fentanyl pills that are disguised to look like oxycodone. That's kind of what's mostly in this area.
Thank you so much. So we're going to exit stage left and start the first segment of the documentary, The Opioid Fix.
One of the things about this opioid epidemic is it has brought a bright spotlight onto opioids, and it is an epidemic. It's a crisis. Major proportion, not only here, but across the nation. This opioid epidemic has affected families, individuals, communities. It is powerful.
I think there was a time when it was seen in this country as a weakness or a moral failure. What we know now, though, is that there's a lot of biology that goes into those behaviors, and those substances come in and they change the way the brain works, and they override and hijack areas of the brain that make it near impossible to stop.
Many patients are trying to find pain relief, and they have an expectation that there is going to be zero pain. And so they start to overuse medication over time. And of course, the body adapts to these medications. It's not as effective. Care, compassion, and understanding is the best approach.
The Opioid Fix is a TPT Partnerships co-production with Mayo Clinic.
They had to go through all the coping techniques and how to get off of it, and what I should be doing to preoccupy my time and things like that.
When I meet with patients, I do ask them what is their understanding of acute versus chronic pain, and the majority of them cannot tell me. They've heard the terms, but they lump pain all as one category. When I explain acute pain, I tell them it's a new pain. It's our human body's way of alerting us to danger or harm. If you're cooking, you're careless, you touch a hot surface, the body knows how to register that information, and the signals are sent through the nerves, the spine to the brain. The brain interprets the information, reminding us to remove our hand. So that ends up with a burn, which is a new pain. And that heals and it's done and it goes away. Chronic pain is a pain that's kind of lingering after the healing has occurred. It's moved into the 3 to 6 month and longer time frame. And chronic pain in our body, travels on the same system.
Most folks we know nationwide who develop an opioid addiction are introduced to opioids through a prescription. We know that's the national trend. I would say that's true of most of the folks that we end up seeing in our treatment program. Now, a lot of folks who receive an opioid prescription for pain don't ever develop an addiction. Actually, most of them don't. But the individuals that do develop an addiction or a substance use disorder, as we call it, and they end up coming into treatment.
When I worked in a pain rehabilitation program, many people came into that program that had been on these pain medications for a long time. They may go up on their medication or try a stronger prescription. It was affecting their overall quality of life and function. They were not able to do as many things physically. Socially, it was affecting them. They weren't doing things with family and friends. What was helpful initially was no longer effective.
This was for sure. And so what we do first is we educate the patients on their illness, why they've done these things that they really didn't want to do at the time, but did them anyway and went on in the brain.
One of the things that patients in your situation are often concerned about is getting off the opioids, having the pain be too strong.
Yeah. You can see the same sort of behaviors in other animals with these same substances. So it's not just a human thing or a moral failing. And then we introduce them to communities of folks that are in recovery, can help them kind of navigate their way to success. They know they're not alone in that process, so that they know there's others there to help them.
It's going where I want it to go. Yep. Tucker and I were in treatment together. We went to Hazelden in Plymouth together, and then him and I were the only two that went out to the Lodge program in Center City right when we finished our treatment. So
I remember the first thought I think I had when I saw you in treatment was, he's tall. And then we I don't know. Yeah, we talked about Suboxone and then we talked about Notre Dame and stuff.
Yeah.
I don't know. There were a lot of people who didn't take treatment seriously there, and you weren't one of them.
I think that's the reason why the two of us were sent to the
actually
Lodge.
Connected and sent to the Lodge, yeah.
I like it.
I was a student athlete at the University of Notre Dame, where I was on the football team on full scholarship for 3 years until I blew out my right hip, ended up having 4 hip surgeries and 2 core surgeries over the course of the next 2 years. In that time, I became fully dependent and highly addicted to the opiates and went into a very dark place. As much as the painkillers were needed to numb away the feeling in my body, I also abused them to numb away some of those feelings of failure and just unsureness of who I am. My older brother and I have been best friends growing up, like as tight as you can get. There were a couple years there to where he had no idea who I was. I think the biggest effect was my absence in that relationship, and I think it was most noticeable for him beyond everybody else.
When young people are using substances, and opioids in particular, their life becomes very sheltered, and they do very limited things. They start to rationalize whatever state they're in as being the normative state. And it's when they can really be honest with themselves and pull back and see their trajectory, then they'll be honest with their functionality, what they expected for themselves versus where they're headed because of their substance use.
I decided to try heroin. I had always told myself I would never do that. When that happened, I knew I was fully, I had no control over this, and this desire, this disease in my head had fully taken over my entire life. As much as my older brother and I were not on steady ground in my family, they never once just gave up on me. And instead, they looked into what I was dealing with. They saw the grip on me that I was unable to break on my own. And so in November of 2017, I drove actually from Notre Dame to Plymouth, Minnesota, and checked in at Hazelden. It was, I need to go do this for me and, for me, for them.
Recovery is a lot about redemption. Redemption requires relationships and the possibility of positive relationships. And young people do better in substance use treatment if family members are engaged as well.
My older brother and his wife are pregnant, so yeah, I'm gonna be an uncle, man.
Being able to be present with my family.
We're gonna be like, when's Uncle Mike coming to visit again?
And not have to wake up every day and worry about anything other than what's before me. And I don't have to rely on a substance or anything else really to get me out of bed in the morning or to go participate in just any sort of activities. I now just feel these genuine happiness about myself and genuine love for myself and for others. And that was just so absent before.
That process of recalibration is what you see beautifully unfold when you see young people in recovery. And they're enjoying themselves and their family members and their friends again. Whereas when they were using, they've lost interest in all the things that they used to like to do. We see a lot of young people who yearn to meet their own goals in life. And when they start to see that their substance use is in direct contradiction with that, they start to make changes.
I was able to come and not only re-identify myself, but build a whole new identity around sobriety. I think it's crucial to know that recovery is possible. To go get help and to seek out treatment and to, say you do need help, I think that shows such strength and such courage to say that I'm gonna go fight for my life because I want a better life.
Wow, incredible, wasn't it? I think I want to start first this time with Dr. Schumann. And if you could, the documentary talks about the use of drugs in pain management, but where does all this pain come from?
That's a really complicated question, and I'm hoping to give a brief summary of where pain might come from and what it looks like. So maybe I'll survey the crowd here. How many people here have experienced pain? Good, that's typical. It's a human response, right? As Joan had mentioned in the video, that pain serves a purpose. For us, it's protection, to say, hey, don't do that. Stay safe, keep the body safe, keep the body alive. Where it comes from is complicated. Pain is an output from the brain, and I often hear the statement, well, people say that it's in my head. While that message and the meaning behind that is absolutely incorrect, the pain that one experiences is real. It's influenced and mediated and directed by the brain and the spinal cord, the organ between your ears. So the factors that influence that volume knob on pain can be a lot of things. One is our biology, and that could be tissue damage, that could be injury, that could be past injuries. It could be psychological factors, mood, stress, traumatic events, and it could be social factors. How people respond to us influence the pain that we experience. Now, if the system is functioning as it should, in acute pain, I break my arm, I get it set, I rest, I heal, I get better. With chronic pain, it doesn't play by those rules. What happens is that system, the brain and the spinal cord, keeps that signal alive and in fact becomes more sensitive to those types of signals. So that's how treating chronic pain becomes complex. Chronic pain isn't just prolonged acute pain. It comes with a lot of forms, a lot of factors, and that's what makes pain unique to the individual, and treating it is difficult. So where it comes from, my simplest response is the brain and the spinal cord, the central nervous system. How it's influenced and what determines that factor are a lot of other factors involved. And thinking about the prevalence. So how many people here know someone or have experienced difficulties with chronic pain? It's one of the most common presentations to primary care clinics, medical offices. Over 100 million individuals in a given year experience difficulties with chronic pain that lasts longer than 3 months and has substantial financial implications in terms of healthcare, lost revenue from jobs and things like that. So I guess that's my quickest answer to that.
Thank you, thank you. Dr. Doffenbach, why do some people get addicted and others don't?
That's, again, a terribly complicated answer. And if I had that answer, I wouldn't be here. I'd be on an island or a beach somewhere. So there's a couple of pieces to that. Addiction being a neuropsychobehavioral, psychosocial condition and disease. And so what causes one to be addicted to any substance? It becomes a very complicated question. But when we look at the opioid epidemic and why we are faced with such an issue with opioid addiction, there's a couple of things that we're starting to understand and starting to learn more about. of why one patient may become addicted to an opioid and one may not. And it ties back into what Dr. Schumann was talking about with some of the effects that opioids have on our central nervous system, the timing of those exposures. There's some interesting theories in developing research about the neuroimmunology. So how do opioids change the immune system within the central nervous system, within that brain and spinal cord, affecting these small sort of supportive nerve cells called glia, and that may be a role in chronic pain and then subsequently opioid addiction. But there are also some interesting factors, work that's been done through CDC, monitoring of data, and recommendations through the Minnesota Medical Association and some state societies about volume of exposure to opioids. We know that when patients receive a certain prescription of opioid medication and for a certain duration of time and a certain volume of pills, we calculate this into morphine milligram equivalents, that we know that as those exposures go up, the risk of addiction tends to follow. And so that's where a lot of our drives now with monitoring of prescriptions, monitoring of volumes of prescriptions after a surgery, or what are reasonable amounts. That's a very subjective answer to that, but we do know that there are some predictors of patients, particularly when we look at from prescribing practices, that put patients at risk for developing dependence or, again, subsequent catastrophic outcomes, opioid overdose. And those are really increased exposure and sort of that timing of exposure as well. So.
Good, thank you. Between the two of you, Thad and Steve, could you? Jeff. I'm sorry, Jeff. Steve's coming up later. Right. Jeff, could you talk a little bit about what does it look like when someone is addicted to opioids?
Addiction's a disease, right? It's a pretty debilitating disease, and many of us are impacted by it. Another survey of the crowd, how many people have somebody in your life, a family friend, who suffers from the disease of addiction? How many people? And so look around. I mean, that is quite a number of people who struggle with addiction in our society. And so I really liked how this episode talked about how most people who use these drugs don't get addicted, and that's true. The majority of people do not develop a clinical substance use disorder to these drugs, but an alarming number of people do. And in part, it's because of the drug and what the drug does, as Jason had talked about, how it changes the body. And so we start to develop what we call a physical dependence. And that is that when you need that drug to function. And so when you become addicted to that physical dependence, the opioid addict is not trying to get high anymore. They're not out there trying to have a good time and party. They're simply trying to fill that need that their body has, because without it, they go through withdrawal. And opioid withdrawal is pretty miserable. It can be compared to like the worst case of the flu you've ever had, right? And so those people who become dependent will do anything to curb that withdrawal, to stop that withdrawal. And that means they may disengage with your relationships, which is a sign of addiction, where people kind of isolate themselves. You saw that in the case of Mike in the episode here. Or they may do erratic things like quit their job because they're spending their time trying to find the drug or recover from the drug. And then these things are expensive. Jeff will tell you, these things aren't cheap. And so in order to pay for this habit, then they start stealing or committing crimes. And so when you think about what addiction is in its totality, it really touches all facets of life. And for an alarming number of you know that because you've lived it. You've seen it in your own lives. And so addiction, a very debilitating disease. One, as you're starting to see, has hope for recovery, but one that is extremely damaging to the individual and the relationships around them.
Do you want to add anything?
Just
Jeff?
real quick, as far as what it looks like, the days of thinking a heroin addict is the homeless guy walking down the street looking like a junkie are over. Everyone in this room could look like an opioid addict. I do presentations with a mother from Mankato who lost her son to fentanyl overdose shortly after he graduated high school. She had absolutely no clue he was using opioids, no clue that she didn't even know what fentanyl was. She had thought that he was on some anxiety medication, and that's why he was having problems with work and school and stuff, and he died, and she had no idea that he was on drugs. So you can't look at someone, you can look at someone and know they're drunk, but you can't tell they're an alcoholic just by looking at them. It's the same with a drug addict. Just by looking at them, you're not going to be able to tell. So you don't know what they look like. You have to engage with them.
Absolutely. Well, let's watch our next 10-minute segment. You're still going to...
Well, I think historically it has a lot to do with our culture. And I know that's a fairly vague term, but it has to do with the things that we value and how we choose to live. Bigger, better, faster, more. That's never questioned. People like to do what they want, have a manifest destiny, have their own house, 2 chickens in every pot, and so on and so forth. And that's how we live. So you see that we not only consume most of the opioids, but the rest of the pharmaceuticals, we consume a disproportionate amount. And you can compare that to fast food or fossil fuels. Lots of examples where there's something in our culture that lends itself to excess consumerism and certain vices like addiction.
So to get going today, what I'd love to do is just do a bit of a free-form process group and let us know your biggest recovery barriers.
Right now, my biggest barrier to recovery is just trying to figure it all out. Like, I'm just totally getting stuck on some of my step work, and I don't know how to move through with what I'm going through, and the emotions are coming up. And so there's this shutting down and not wanting to do it. And so I would definitely love some group process time.
People have been struggling with opioid addiction for a long time, all across the world. And there have been disadvantaged communities that may fit more of the stereotype of what people think. These are the people that get addicted. And those people have been passing away without help for a long time. The prescription drug epidemic brought the fire of addiction, and opioid addiction in particular, to the suburbs. And in our country, when white kids in suburbs that didn't stereotypically look like people who should be addicted started passing away, the nation started to pay attention. So it has completely ravaged the country. The numbers are incredibly tragic, and we're still in the middle of the fight. And we should honor the memories of people who couldn't get help when there was greater stigma as we roll on efforts to combat it.
It's good to see you. I'm Dr. Schumann.
Nice to meet you.
I'm glad you're able to come in today.
I really do think that we are starting to approach a more holistic perspective in terms of how we treat patients. Certainly, I see that in the medical students that I have the privilege of getting to work with in terms of their training and their curriculum really being focused on the whole person.
You met with Dr. Brown.
Dr. Brown was my doctor for 20 years.
Yeah.
I'm an attorney in town, and 3 years ago, my client was convicted of domestic abuse, and when he was found guilty, his dad hit me and broke my jaw and several places, and I've had multiple surgeries, and now I just have this chronic pain, and nothing. We've tried, you can look at my records, we've tried everything, all different medications, therapy, and Dr. Brown prescribed the oxycodone, and it's the only thing that allows me to function. So I'm constantly in pain. I have a 5 or 6 on the pain, but can't get any lower than that, but at least I'm able to do my job.
Yeah, and I can imagine that difficulty in that situation.
I have run a simulation workshop with the medical students. So when they are in their psychiatry clerkship, which occurs in their 3rd year, we give them some brief training on pain and opioid use for pain and the problems that represents and the opioid epidemic. Do you feel like you were learning from each other? Some words I want to borrow, or I want to use that explanation. Was that helpful?
Yeah, today I even already found myself borrowing some of my classmates' language that I liked. I think I took something from all of you.
We have actors who are playing the parts of patients for some scenarios that I've developed to give them experience in how to compassionately say no to giving opioids for pain, but instead explain pain, explain what effective treatments are for pain, and direct them into types of interventions that would actually be much more effective and safer.
I was working 60 to 80 hours a week, and now I'm able to function enough that I do about 30 hours, but I don't feel like I'm carrying my weight. You just act like a normal patient. You're given a scenario, you're given different problems that you might have, and the doctors or the script will tell you how to act it a certain way, or they'll come in and say, for this next student, switch it up and be angry or, flirty or whatever.
And you mentioned that the opioids are the only thing that are allowing you to function. What does that look like in terms of functioning?
Well, it's allowing me to at least keep my job.
And you're still in that job, working as a
I
lawyer?
am. I was.
When it comes to right after the surgery, they had me on the IV for a little bit longer than expected. And then they gave me the 7 days of oxycodone.
It's written specific, but enough vagueness that the student really has to pull out what's really going on and my function in life, and if I'm living a quality life, and what are my goals.
I definitely went through those a lot faster than expected, so I got through my 7 days worth in about 3. So that was a real issue. I'm kind of out of money at the moment, and I'm also just trying to pain manage as well. So it's kind of a difficult situation.
Who's this guy?
He has been my husband, he's been my father, and he's also been my daughter. So they have a really great wig they throw on.
Yeah. So you mentioned that ordering from a non-prescriber was an old habit. Can you tell me more about what happened before?
And it's kind of fun because you have the license to push back if they're not handling it well, or they're coming across judgmental, or making it sound like in your head, and cause them to think and re-say things. And then you have great debriefings afterwards.
It's hard to reverse what previous providers have done as far as, the second that you say, the brain is what receives pain signals. Well, it's all in my head. Somebody else is telling me it's all in my head. You're gonna tell me it's all in my head. And so I think gently walking that back, and that's...
I think the interesting thing in working with medical students is that they're just into their 3rd year of medical school. So they're just launching into actually working with patients. And so they typically are very open and willing to learn these new skills, and understanding that we need to be more effective in the treatments that we provide for patients.
It's a hard balance in that way.
We're back. We're back. I want, back again, and back from up there too, right. I want to turn to our clinicians first, and ask first Dr. Doffenbach and then Thad to talk a little bit about what does treatment for opioid addiction look like.
So when we look at treatment for opioid addiction, in particular, we use sort of a two-part method. If you look at this and say, well, we can use an abstinence-based program, okay? And that would be a treatment program very similar to what you would look at for addiction for other substances, where you would say, well, I'm not going to expose myself in any fashion to alcohol, for instance, okay? We're going to be an abstinence-based program and utilize a lot of interventions that I'll let Thad talk about a little bit. When you contrast that with opioids, we talked a little bit earlier about what opioids do and the mechanisms and what they function, or mechanisms of how they affect us, and that sort of avoidance of that withdrawal syndrome. So as pharmacology has evolved, we utilize a series of medications. There are 3 FDA-approved medications that could be used to treat patients with opioid addiction, and something that's called medication-assisted therapy. And what those what those MAT drugs do, things like buprenorphine or Suboxone, which was mentioned, I think, in the video earlier, methadone, or Vivitrol, which is a medication that can be injected. But what they do is they help stem that tide. They partially activate the opioid receptors in our body, so it really prevents or mitigates, is probably a better way to say that. It lessens how these patients have cravings for opioids, or how they have an exposure if they do relapse, that medication or that substance, that heroin or that opioid pill or tablet, doesn't have its effect like it used to. And so there are a series of medications that are used and prescribed from a practitioner standpoint, or from a physician or a nurse practitioner or PA. you have to undergo certain training, a level of training that's, I think, 8 hours. There are some colleagues here in the audience that do this as part of their practice from a family medicine perspective. And so as a pain medicine specialist, I personally do not utilize opioid medications, or rather a medication-assisted therapy for treatment of addiction, but that looks like meeting with patients, that looks like establishing a care plan. And what's a crucial component of this, and if we step back and look at CDC guidelines and CDC recommendations for prescribing, when you look at the best evidence, there was a big change. I think it was 2016 when these CDC guidelines came out and really started stemming the tide of opioid prescriptions. The quality of evidence behind those recommendations was really moderate at best, except for number 12, which was the institution and the use of medication-assisted therapy for the treatment of opioid addiction. And so that has the best evidence. That's level 1 evidence for the use of these medications. And when you look at across the board who is responsible, who is engaging with this, really it comes from our primary care colleagues, because those primary care providers and physicians are the most commonly seen providers, and those are the people who are going to see you in clinic and hopefully start to rebuild that therapeutic alliance for patients. And so that really looks like establishing a care plan, engaging with psychology and psychological interventions, because as we know with anxiety and depression, pills are not the answer. And in fact, that's why the label is there, medication-assisted therapy. The medications are only a small portion of how these patients are treated. And it can be very helpful. It can be vastly life-changing for patients that get a chance to engage. But you have to recognize that these are medications. They do partially activate and partially act upon the opioid system, so they are dangerous. They don't come without potential death, really. You know, methadone is a treatment that's been used for years in treatment of opioid addiction, but it was for a long time, until it was surpassed by fentanyl, the most common medication that patients would die from. So these are tools. They are controlled substances. That's why they're not on the shelf next to the nicotine gum or nicotine patches. They still have to be engaged with by a medical profession.
Thank you. Dan?
So to tackle the psychological side, I think it's important to start with this understanding that there's only one reason that people use psychoactive drugs, just one. There's only one reason people use drugs like opioids, methamphetamine, alcohol, and that is to change the way they feel. That is universal. That's the only reason people use these drugs. Where it gets a little more tricky is that there are literally infinite reasons why people need to change the way they feel. And so there's a whole subspecialty in healthcare of drug and alcohol professionals who are trained to treat people who have these addictions. And part of that training is to help the patient figure out what is it that needs to be changed. Are they using chemicals to mask things like depression? Self-medicating, a pretty common reason people use psychoactive drugs. Are they covering up traumatic experiences? What is the reason they need to change the way they feel? And if we can help patients figure that out, we can then maybe give them new tools, non-chemical tools, to combat that depression, that anxiety, even in chronic pain, and how you can deal with chronic pain. I think it's a question we have toward the end of this panel about what are the other ways in which we can deal with pain. And there are lots of psychological tools that we can teach patients in order to hopefully, slow the epidemic.
Thank you. This is for Jeff. Addiction is bigger than just the individual. Can you talk to us a bit about what the impact is on family and communities when there is an individual with an addiction?
Sure. Well, as far as family goes, it's terrible when you have to go to a family and let them know that their loved one died of an unnecessary drug overdose. And a lot of times, like I said before, they have no idea their kid was even on drugs, or they pushed them out of the home, or didn't. They put it in the back of their mind, and they're going to get better. I don't want to be embarrassed by having a kid addicted to drugs. And pretty soon, they're gone. Either they're dead or they're completely gone. Their brain is gone, and they're out of their life, and it's just not good for family. As far as communities go, you look at the violence that drugs bring. It's not the drug addict that's committing the violence, rarely. When there's a market for drug sales in the community, it brings in people selling drugs. Drug sales is big money. You would not believe how much money exchanges hands in this country for selling illegal drugs. Along with that comes violence. Very rarely do we do a search warrant now in a drug house where we don't find at least one firearm. They're carrying the guns with them. They got them underneath their pillow. The drug task force I'm on, it's state funded, it's a violent crime enforcement team, because routinely you can ask any law enforcement officer, if you go to a violent crime, there's drugs involved almost every time. Either it's a drug deal, either it's a person like Thad said that's addicted to drugs and he's trying to get some money. But drugs and violence go hand in hand, and if you look at any violent city in this country, I can guarantee you they have a huge drug problem. So if you have a lot of drug addicts, you have the market for it, and it just tears the community up.
There you go. Thank you so much. All right, we're going to exit for our last segment of the opioid fix.
Is a developmental disorder. And that's just not a catchy phrase. When you actually look at the ratios of when people actually develop meaningful substance use disorders, most of them develop substance use disorders between their mid-teens and mid-20s.
The last thing I remember was lying down in my bed. The next thing I remember after that was my roommate standing over me saying, "Wake up, say something, you need to wake up." Kind of rubbed my eyes and I was like, "What's going on?" And he was like, "Dude, you were dead." I think I had my first drink when I was 13 or 14. For the first time in my entire life, I felt like I could breathe. The anxiety, the depression, the low self-esteem, all the things that I had been struggling with for as long as I could remember, it all just kind of dissipated in that moment. First it was drinking, and then it was drinking and smoking, and then in August of 2015, my best friend who I'd grown up with died. That's when the alcohol, the cocaine wasn't relieving the pain the way it once did. And heroin had always been that line. It went from trying it to daily use within a matter of weeks. And that kind of went on for 2 years. I went through periods of homelessness, sleeping at different homeless shelters, just so I could continue using. And that all kind of culminated in an overdose. That was the aha moment that took. That was the one where I was like, okay, this is, I'm gonna die. I'm not gonna make it another year if I continue living the way that I'm living. Week after that happened, out of nowhere, my parents just showed up and they came down there and they were like, we're gonna get you the help that you need. And they helped usher me off to Minnesota.
What I tell young people is that there are millions of people just like them, and that there's hope for them, and they shouldn't have shame about their use. We've seen a lot of young people that I think others may have written off due to adversity or trauma or difficult circumstances or mental health issues or lack of compliance, and we've seen many cases turn it around.
What I didn't realize I needed until I came out here to attend Hazleton was I needed to see other young people being successful within recovery, so that connection could be formed. Because that's really what's at the basis of all these programs is connection.
He's an iron guy off the tee.
No drivers. All Iron Man.
Well, addiction's always been about people and not drugs. And those relationships need to be fostered by getting to know people on an individual level, not just what symptoms they have.
That's what they call me now.
Yeah.
From now on. I will only be referred to as Iron Man from here on out. I've realized that the things that I've gone through have all been building blocks to get to a place where I was able to be saved by this community, by this program. The people there, the counselors, the techs, my peers in the program loved me before I could love myself.
Get in the hole. Yeah! How about that?
am I optimistic? You know, in a typical psychologist fashion, I have to give you a multiple part response to that.
I don't think the opioid crisis is going to end. I hope that it tapers. I hope it becomes less of an issue, but I think that this will always be something that we need to consider. I think what we can do is minimize the role that physicians and surgeons play.
I worry that this is going to go on for a long time, that it's making people scared. They're scared to take pain medicines even when they should.
The concerning portion is that there are providers that go 180 degrees the opposite. So they maybe have been treating a patient for years and years on chronic opioid, and now they're feeling pressure to reduce their prescribing, and so they're cutting individuals off.
So this house here, we had well, there were several individuals there. They had gone down to the cities to buy heroin earlier in the day, came back to Little Falls.
In the average clinic, half the town doesn't even know they have heroin. So a patient's not gonna show up to a clinic saying, I have a heroin use problem, help me. Very rarely, but they are gonna show up in the ER sick, withdrawing, or just overdosed. If we can catch them there, the whole community will be better.
I'm optimistic if we can get people to plant trees that may not bear fruit right away. And that's something that's also culturally hard to do in our society. We want things with sexy results right away within that politician's election cycle so they can demonstrate they can do something. But actually the best prevention programs, when you're really trying to strengthen a community, those things sometimes take a generation to take seed. Prevention won't get everyone, but it is so cost effective, it's a no-brainer.
I think that most people want to do the right thing. Most patients want the right kind of treatment. Most providers want to give the right kind of treatment. There is a great capacity in this country to help curb this epidemic of opioids. I think people have been so exposed to the dangers of it and the absolute tragedy of it. I saw a patient last year who had seen her provider over the course of a year and a half, multiple times, complaining of abdominal pain. I have pain right here, she would say. By the time I saw her, she had lost about 20 pounds, was pale, and was laying in bed all day long. And I remember looking at her chart and all of these records of her going in and, you know, sort of having that feeling myself like, is this what she's all about? She just wants to get pain medicines. Not whatsoever. I went into the room and asked her to tell me her story again, examined her, and ordered the MRI that diagnosed the lung cancer that was eating through her spine. And I still care for that patient. She had a great mistrust of the medical system after that, but I think it's critically important that we not have a selection bias or that we not have bias when we are seeing patients, assuming something about them before we know the truth.
I am optimistic in that there is a growing conversation about these behavioral strategies that can be very effective. So the fact that what our program has been telling patients and providers for many decades is now really being backed by these large institutions that are really backing up the data, that makes me feel hopeful. I have the pleasure and privilege of getting to work with patients every day who experience an improvement in their functioning and a return of that sense of hope.
Oh. Perfect, perfect. So there's the documentary. It's clear pain isn't going to go anywhere, so I want to start with Dr. Schumann first. What are some of those alternatives to treating pain other than opioids?
So a lot of the patients that I see, so I work with individuals that have experienced chronic pain and are experiencing chronic pain. And often a lot of the interventions, surgeries, injections, procedures, medications, and still pain persists. So we focus on utilizing different strategies like cognitive behavioral therapy, acceptance and commitment therapy approaches to improve function. Because we know if we keep trying to focus on and chip away at that pain severity, often a lot of interventions have already tried that to little minimal success, which is extremely frustrating. So we focus on engaging in activity despite pain, training the brain to show that hurt doesn't necessarily equal harm, and increased physical activity can lead to return to conditioning of the body, and it changes how one thinks about their pain. Interventions about pain in and of itself, talking about pain, how the pain system works, differences between acute and chronic pain, is an intervention in and of itself has been shown to improve physical functioning for individuals with chronic pain as well. Other strategies include, well, if you think about evidence-based approaches, comprehensive pain care is important. So from a psychological perspective, those are the things that I focus on in terms of moderation, behaviors, thoughts, and emotions associated with the pain experience, but also physical therapy, occupational therapy, yoga, tai chi, mindfulness, relaxation strategies, all of which can help soothe that central nervous system and help improve functioning. What we know in terms of the evidence and working from a pain rehabilitation standpoint. So Dr. Morrison in the video is one of the faculty in the Pain Rehabilitation Center. It's a comprehensive, it's a pain boot camp, 8 hours a day for 17 days straight, getting all those different disciplines in one, focusing on function and not pain severity, and individuals improve. Individuals walk further, they tolerate activity more, their moods improved. And what we know is that getting at quality of life and improving quality of life, turning that volume knob up, it helps decrease or keep that pain volume knob where it is. And by the way, the individual is living the life that they want to live, their values, the things that are important to them. Other strategies that have been effective are things like biofeedback, monitoring purposeful control of the central nervous system or the sympathetic nervous system response, so heart rate, respiration rate, things that we can help slow down through the use of relaxation and diaphragmatic breathing. I often kid that when I work with patients, when we ask them in their progress within the Pain Rehabilitation Center, what's the one skill that they find most effective for their pain? And they say breathing, something we do all the time. And I figured we got to find something fancier than breathing, or brand some word and market breathing better than just breathing in of itself. Slowing that central nervous system, decreasing fear avoidance of activity helps improve functioning.
Thank you. Thad, do you want to comment, and then we'll come back down here?
So one of the areas in which I spend my academic research is in the area of therapeutic cannabis. I am on the governor's task force for the use of therapeutic cannabis. And just this year, the Department of Health has authorized chronic pain, to be one of the diagnoses that can be using therapeutic cannabis. Now, I'm not up here saying everybody should just jump to cannabis from opioids. That's a bit presumptuous, but I think it's important to recognize that pain isn't going anywhere. You heard the dean say that. And so what are all the strategies on the table so doctors and patients can make better decisions about what's best for them? And so I'm not up here as a marijuana proponent saying that is the answer, but the data is coming out, the research is suggesting that for some patients that may be an alternative. And if we think about the long-term consequences to a drug like cannabis compared to a drug like opioids, there are better outcomes when it comes to that. And I think that's in part why the Department of Health has authorized chronic pain this year. It's been on the docket for our panel for a number of years, looking at is this something we want to go down here in Minnesota? And my advice to the legislators and the people who make that decision is that we need to go slow, because this is how we got into this problem in the first place. The best way to kind of see the future or predict the future is look what we did in the past. And if you look at drug trends throughout history in this country, we've always raced to a result that ultimately has caused a lot of consequences. And so, am I optimistic about what therapeutic cannabis may do in regards to pain management? I would say so, but I think it's way too early to say that is going to be the magic, the magic pill, I guess. Not the magic joint, the magic pill that may end some of the extreme use of these pills.
Thank you. Dr. Doffenbach, you want to comment as well?
So in regards to ways to treat, so treatment, where do we go? What do we do? And as you alluded to earlier, part of what I do is addressing patients from implantable devices, treatments, and so forth. So I want to come back and just touch, what is pain? I don't think we really touched on what that is. And so you talked a little bit about what pain is, and you look at a textbook definition, and that becomes a signal, it's really a biochemical signal of tissue damage. And part of that's the education that with chronic pain, that is no longer that tissue damage. So the education, I think, is one of the biggest pieces that I do in my clinic day to day is recognize that it hurts. It hurts to do this, but you're not hurting yourself. You're not causing worsening arthritis. You're not causing more nerve damage. But that's also crucially important. What Dr. Gazelka talked about is finding the correct diagnosis. Okay, sometimes that diagnosis is a chronic pain syndrome, but not being presumptuous and not sort of jumping to conclusions before you even walk in and meet a patient. So first of all, it comes back to what is their medical diagnosis. That's, I think, the first piece. And we look at, okay, there are recognized conditions that induce, chronic pain syndromes. And some of those pieces, from our standpoint, from a specialty of pain medicine, some of that is exciting types of electronic devices or implantable devices that involve placement of a neurostimulation device that can help mitigate, once again, or change some of those signals that are coming from an impinged nerve or a back that's been operated on 3, 4, 5, 10 times. So things like spinal cord stimulation. We have a number of medications that are delivered right to that spinal cord system that are non-opioid. So opioid-sparing medications that, once again, affect how those neurochemical signals transmit from a damaged body part. So drug pumps. And that's not necessarily a pain pump. That can be other types of medications that are infused. And so all the way from exciting sort of neurobiological and immune-mediated medications that are coming probably in the next 5 years, that we'll start to see a variety of different categories of medications that should be addressing these pain pathways without addressing, again, as you alluded to, that about trying to not replace one problem with another, trying to address really the chemical side of things. So pharmacological aspects of pain, I think, are coming very quickly, and it's being pushed for a number of reasons, from legislative, from social, and from medical side, because we were sort of closing our eyes. 25 years ago, we closed our eyes a bit and were led astray, and I think we're paying the consequences of that day to day, but we are going to get there. We'll get there.
Wow, thank you. So interesting. I want to turn to Jeff now. Much of our discussion certainly has been on at opioids, but from your experiences, what other concerns do we have locally that would be related to drug abuse?
So methamphetamine is 100% the major legal drug problem in this area. A lot of people thought, well, it was the media kind of, when the pills were put behind the counter in 2005 or 6, I believe it was, basically the media quit talking about the meth problem for a long time because they thought, meth was taken care of. Now that people weren't making it, in their homes or in their motor homes or garages or whatever. But I can tell you that it has gotten 100 times worse. It's extremely cheap. It's everywhere. 100% of it comes through the southern border, produced in Mexico, and the drug cartels are making billions of dollars off of it. Methamphetamine just doesn't get the kind of attention I think it deserves. That by far is our major issue. Last year, the 5-person drug task force that I supervised seized 125 pounds of methamphetamine. That's up from about 5 pounds in 2018. So it really rose, and I think this year it's going to be just as bad, if not worse.
Wow, that's incredible numbers. From all of your perspective, what are the next steps? What should we be doing as a community?
I'll start. I think this is what we need to be doing. I'm very proud of the fact that my colleague Jennifer Lundgren held a opioid symposium 3 years ago on this campus. It's been something that we've been talking about for a very long time, and that's the first step in reversing this problem is education, educating people about what's going on, and you're all playing a part of that right now. None of you can leave today and say, I don't know anything about the opioid epidemic. You just can't do that. You spent the last 90 minutes learning about it, and that is a key, crucial first step. The other piece is we can't forget that the best form of treatment is prevention. That we often focus on the treatment of the problem, but we lose sight of that. It's much more cost effective to prevent the problem from happening in the first place. And so we're seeing kind of an emphasis placed here in this community and across the country on how do we prevent young people from starting down this path. Because I'll tell you, in the thousands of people who suffer from addiction that I've treated over the years, I've never met anyone who said, yeah, it was my plan all along to get addicted. I've never met anyone who said that. It's a process that happens. And the more we can talk about it, the more we can educate people about it, we can prevent it from happening in the first place. And so my answer to you, Dean, is they are all part of this next step of doing something about it here in our community.
Thank you. Others?
I think from our medical practice, those pieces are in place. Some of the first steps are in place, and that's changing the way that we prescribe these medications. Prevention, not letting these pills sit for weeks, months, years in the closet or the cabinet to get into the wrong hands, to get into a curious mind. So those pieces are in place, partially because we as a medical community didn't act fast enough. So we are now having to work with our governing bodies and governing societies to meet those requirements. It takes more work and a day-to-day piece for me to get a prescription to a patient, but that's what it has to take. And we have to think about this, and we have to change our expectations when we interact with our medical providers about what is a goal. Again, partially understanding where this has taken us and where we are now with chronic pain and opioids, and recognizing that they are not the panacea we thought they were. So we need to change our expectations, and that's partly what's talked about as a cultural shift. So from my little piece of that pie and our little piece of that pie from medical providers, we are starting that process and we are doing that, but it takes time. It will take time to change the way that we prescribe these pills.
And as the video depicted me working within that simulation center, Dr. Sperian and I put together a workshop focusing on conversations, how to have those difficult conversations about opioids with patients. And so starting with the medical students getting familiarity to know what questions to ask, how to assess for addiction from a medical standpoint, and then being familiar with what are the biological, psychological, and social prescriptions that a medical provider can provide. Some of those include different management of medications that are non-opioid in nature, and also including different ways to increase physical activity, identifying ways to incorporate relaxation strategies, cognitive behavioral therapy, acceptance-based approaches, and also socially, finding ways to have the patient talk about their symptoms with with their family members without being at the focus. Often individuals don't want to spend their time giving their family members an update on their symptoms. They want to talk about the things that they enjoy. So finding a language to talk about that, all within a patient-centered, non-stigmatizing fashion. So when we think about next steps, I think it starts with the next generation of medical providers and ongoing conversations about what are different options to help manage pain. And the key word there is manage. Rather than trying to eliminate or get rid of it, how do we find ways to manage pain if it's just going to stick?
Thank you. Steve?
By the way, thank you, Dr. Schumann, for being a good sport when we were down at the simulation. In the first show, we talked with Elizabeth Haberman from Mayo about the research that they were doing. I just want to say that research is really at the front end. So, presumably a lot of you are interested in getting in healthcare. It may be you who does the research that breaks through on solutions for this. The other thing I would say, and the lieutenant can correct me if I'm wrong, but the sea change in the way law enforcement views these issues, whether it's in Stearns County, Olmsted County, northern Minnesota, wherever we went, You know, a lot of the people in law enforcement told us, look, you know, I'm a cop. I got into this to put the bad guys in jail. But in each of those cases, they're also seeing a sea change in the attitudes about, well, you know, as opposed to dealing with everything in a punitive way, are there ways that law enforcement can get people into treatment? You know, cops see people at their absolute worst moments, and if there are effective ways that we can get people into treatment, I think that would also be another big help.
Thank you. We're going to open it up to questions, so start thinking about what you want to ask our panel. But before we do that, I would like Thad to talk a little bit about what to do if you have concerns about someone.
Yeah, it wouldn't be an educational seminar if we didn't acknowledge the fact that if you or somebody that you know is struggling with a substance abuse problem, there is help. And so each of you were given a program as you came in. We've listed some resources. If you're a student, you have resources right here on campus. You have the Counseling Center, which is free for students, absolutely free. And there's also Student Health Services that has medical providers and other people who can help you. So if you feel like you're the one who is struggling with a chemical, or you think that one of your friends or your roommate is having that, just know that we have resources right here on campus for you. If you're part of our community and you're struggling with this, there are lots of resources both here locally at the national level, and there was far too many for me to list on the program, but I gave you a couple of local options, some phone numbers, a website to visit. And so if you find yourself in there, if you find yourself in that place, take that step. Take that step to get that help so the next documentary that comes out isn't about you and your friends. And so be that beacon. Help the person next to you. If it's not you, it's somebody you know. Nearly all of you rose your hand. Connect those people to those resources because there is help. And as you saw in the documentary, there is a life in recovery.
Thank you. Thank you so much. So we have students with microphones. Got it. Questions for anyone on our panel or for the panel in general? Oh, I see a hand over here.
Thanks for doing this. This was really great. And I'm not an audience plant, but I mean, I want to give a shout out to the PRC. I wasn't expecting you to talk about that, but I had a loved one 6 years ago who went through that program in Rochester, and she's just fine and living on her own and doing all her activities of daily life. And when we went there with her, we didn't think it was going to stick. And folks, I mean, that's a worldwide unique program that you're promulgating there. The people there were from all over the world who had gone through everything, couldn't help, and they had run out of ways to help, and that was and it was revolutionary then. That was 6 years ago. That no medication, no, you know, trying to learn how to manage that pain. Thank you for your work on that.
Absolutely,
and I'm
that's
not a plant.
fantastic to hear.
The other, just a real quick question was the detective mentioned fentanyl, and I thought fentanyl got into drugs by accident, like it's from, like it gets mixed in or something. But did you reference that people are like seek it out and use it?
Absolutely, it's no accident. All the heroin that we test now contains fentanyl. Fentanyl is not, or heroin is not marketable anymore unless there's fentanyl in it. It's just not strong enough. So the information that we have is that the heroin is still produced mostly in Afghanistan. It makes its way to Colombia and Mexico where the fentanyl is mixed in, and then it comes through the southern border. As far as the fentanyl pills we find, the people that are buying these pills think they're buying 30 milligram, 20 milligram oxycodone because oxycodone pills are very valuable. And in fact, they're artificial or fake oxycodone pills, and they're 100% fentanyl, extremely dangerous. The one overdose death that I made mention to, the girl thought she was buying 30 milligram oxycodone pills. She crushed half of one up in a pill grinder and snorted it, and she was dead before she hit the floor within seconds. So it's extremely dangerous.
And thank you for your question. Other questions?
Hi, I'm Cecilia. I'm studying community health ed. And I was just wondering, are there any resources in the community for people whose parents are addicts, like in schools for children who might have be struggling with their parents are addicts?
Wow.
Great question. Thank you. There are lots of resources, whether you're yourself struggling with a drug or alcohol problem or you're the family member of somebody who struggles with a drug and alcohol problem. And what I give advice, I suppose, as far as where those resources are at, I don't have any off the top of my head, but there are great people in the Mankato School District or in all school districts. And so starting with the school social worker, starting with school counselors, asking about what those resources are, and I'm assuming that they would then know where to connect that young person. And if not, tell them to not stop there. Keep asking until they get that response, because those resources do exist out there. And so we just got to make sure we get the people to them. So thank you for your question.
Great question. Anybody? Other questions? Yep.
Hi there. My question is for Jeff or possibly even the local law enforcement. So I know either Blue Earth County or maybe even the surrounding counties have just started carrying naloxone or Narcan. How is that being received within local law enforcement? Is that being negatively received by either the community or those that work with the local law enforcement? I'm a health educator here within the.
Do you mean does law enforcement negatively receive it?
Correct, because what I was told by somebody is that they weren't sure if they could carry it, and so then when they started carrying it, I just haven't heard back. And so I would just like to know the feedback.
It actually, I'm sure there's some cops that complained that there's one more thing to carry when they first got it. I actually asked for it years ago, mainly to protect members of my team when we were in people's houses. But now all the cops are carrying it. Well, I don't know about the PD. I think they are. The sheriff's office does. And I know for a fact that the Mankato PD have saved several people just because they have it on it. So they think it's great. It's not something anybody wants to do, is have to administer that, but it's better than dealing with someone that's passed away and then having to tell their family and all that. So it's been very positively received.
And for the students who are unaware what Narcan is, it reverses the effect of an overdose. And so if somebody is suffering from an opioid overdose and they're dying, essentially, this chemical reverses that effect. And so when it's administered, you can actually bring somebody back from that. So if you're kind of wondering what are they talking about with that, at a very basic level, that's Narcan or naloxone.
I was going to tag onto your question a little bit. One resource to that is in fact the reversal, opioid reversal agent. So Narcan, naloxone, it has a commercial product that's used or available. The Surgeon General for the state of Minnesota has a standing prescription for any resident in the state of Minnesota who wants to obtain a Narcan prescription or a naloxone prescription. You can go to your pharmacy without a script, and the pharmacist will dispense that medication. It comes in really 3 formulations. One is an auto-injector. It's kind of like an EpiPen. One is a nasal spray, which is the more commonly available. And then there's also a kit that is available through a variety of sources where it's actually a vial of medicine that you have to draw up and then administer. And so to talk about, again, your question back over here about is it okay to give? Can you give that? Is it safe? Am I protected? Maybe that's not the question or not, but it's okay to give. We are protected as a resident of the state of Minnesota. It's a Good Samaritan Act in order to administer that medication to anybody. So whether it be a family member, a friend, a stranger, a classmate, somebody else at the party, whatever it is, if that medicine is given, you are protected from any negative effects, legally or otherwise, and you can save a life. I actively promote this for my patients that are at any risk, and that's again where the excuse me, my reminder there. But that's another substance that can be that point of at the most lowest that can help save a life, and so that is one resource that I would emphasize.
Thank you.
This question might be more for the providers, but how do you respond to patients that are prescribed opiates that are so scared of being addicted that they're not adequately managing their pain?
So that's a common, I'll say a common thing for our parents' age, right? So they lived through the 80s, the drug wars, and all of those things that were very commonly in media. And so patients that come in that have a cancer-associated pain syndrome that may say, I can't use that, I'm struggling, I'm going down that path of loss of function. And Dr. Gazelka even alluded to that in the video here, that really that comes from emphasizing the education, that this is a tool, okay? If patients are being treated for a cancer, and that tool is no longer, that cancer drug, that chemotherapy agent is no longer needed, that we stop that. That it's okay to utilize these medications when supervised, and that's where the term a controlled substance. We as providers need to control that. We need to take ownership of that and engagement with patients to really monitor function, to monitor side effects, and to look at some of the other psychosocial aspects of that patient, the environment from which they come, the family who comes with them or doesn't come with them, and to look at, okay, is this the right tool to use today? And if it is, we're going to utilize this, and we're going to monitor, and when the time comes to put that tool away, I will help you do that. And that's a common theme that's, I had my knee replaced, and nobody told me how to stop these medicines. So we need to engage that. It's patient education, I think, is the biggest piece. But at the same time, you don't have to, okay? Pain has never killed anyone. The experience of pain. Some of the things we do to treat pain, medicine, surgery, injections, all these kinds of things, that can cause pain. Or that can cause bad outcomes. That can cause people to die. But the flip side of that coin is also the experience of pain and where that comes from a psychological toll. That can take people down a very different path that also ends poorly. So we have to balance that, but recognize that these are tools that need to be used, and when they're not, we put them away.
And speaking to one of the questions that was raised initially, the use of opioids in America and the prevalence compared to other countries, as Dr. Doffenbach has alluded to, had typically been used as a tool, short-term, post-surgery, or in palliative care circumstances. Being mindful of the function of the opioid as a tool is something that should be always considered, and the side effects and interactions that come with other medications that individual is taking as well.
Thank you.
So I have the microphone. I just wanted to touch on a few things, I'm right here, that you guys had said. My husband is a veteran, and he has chronic pain, not surprisingly, and he is starting biofeedback this week, so I'm very hopeful that that is going to help with his chronic pain. But Thad, you had talked about therapeutic cannabis, and that has been a wonderful thing for him in many aspects, because he's able to function through his day, but after the end of his day of working, that's kind of when his pain sets in. And so, and he feels very, he started it a couple years ago, and so he feels good that it's through his disability that he receives it, and that it's so well regulated through the state. And so, it's not something that he ever tried before, in any other capacity. So I am happy that it is something that they use. He also has PTSD, but so it's used for many things for him, but his chronic pain is definitely something that it helps with. So those are definitely some things that help, and you guys touched on both of them. So.
Okay. Is one more after this? Oh, this is our last question.
Here not only as a medical professional, but as a parent of some soon-to-be teenagers in this community. So my question actually is for you, Jeff. I was very pleased to hear you say in the opening segment that we are lucky in this community. However, I don't think luck is always by chance. I want to hear from you, what is it that we're doing that we need to continue to do to maintain our luck?
Well, we're lucky when it comes to heroin and opioids. I can say that when it comes to some other drugs, we're not so lucky. I think, all in all, I think people in this area are real good at being parents. I preach that all the time. In the age of cell phones and stuff like that, I know a lot of parents that want to give their kids privacy and they don't go into their room, their telephone, or their car. And I don't understand that, because you own the telephone, you pay the bill, you own the car, and you own the house. If my teenage son wouldn't give me the passcode to get into his phone, he wouldn't have a phone anymore, right? You got to be careful not to give your kids too much privacy and too much freedom. Have a good relationship with them. Whereas if your kid experiments with something at a party, they come home and tell you about it versus hiding it from you. As far as the opioids and the heroin goes, it was touched on. The Native American reservations around the state really do have a problem. The surrounding communities around them have a huge problem, and we don't touch a reservation. And we're far enough away from the metro and far enough away from Rochester, the highly populated areas. There's just not a market here for it. I don't 100% know why, but there's not. And that's why I say we're lucky. We're lucky because it hasn't hit us as bad as it hits the other part of the state.
All right. Thank you. Thank you so very much for your questions. I want to remind those working professionals who have joined us today to stop at the desk to make sure you get your CEUs for this event. I also want to point out that in order to see the other two segments of the documentary, you can go to TPT. And then I want to thank all of Mayo, who did so much groundwork in allowing this wonderful opportunity and event. Thank you again to our panelists. Wow. Thank you, Thad. You bet. Thank you so much. I think